So the MPS disorders have some very typical features common across all subtypes, and that's the coarse facial features, the prominent brow, the enlarged tongue, the coarse hair, short stature in many cases, and some growth issues. And those should all prompt the exploration of the MPS disorders. However, there are very mild and attenuated forms of these disorders, and the features might not be so prominent, the dysmorphic features that are associated with these disorders, or they might be early in their stage before the GAG deposition has led to coarsening of the facial features. So some key tips for fellow physicians, if they're in different subspecialties, is to think MPS when you have a patient presenting to an ear, nose, throat doctor for recurrent ear infections, obstructive sleep apnea, the need for myringotomy tubes, need for tonsillectomy, adenoidectomy to help with the crowded oropharynx. And those might be subtle, associated with other subtle features of a prominent brow and possibly some short stature or growth delay. And on further examination, they might have some hepatosplenomegaly that's not overwhelming, or an umbilical hernia. So it needs to be on the radar for ear, nose, throat doctors to think about why this patient's having a recurrent ear infection, or what is the mechanism of this obstructive sleep apnea. And those are common features of MPS disorders that will worsen with time. And if we can intervene earlier, not with just surgical correction, but with the specific IV enzyme replacement therapy, we can start to ameliorate these symptoms sooner. Another subspecialty that might see these patients are orthopedics. Several of the MPS disorders will present with growth delay or short stature. They might have the appearance of an achondroplasia. The skeletal findings in MPS disorders as a group is called dysostosis multiplex, and can lead to characteristic findings in the skull, the vertebra, the hands, and in the hips. And so it needs to be on the differential for patients who are referred to orthopedics for evaluation of hip dysplasia, of any abnormalities that might be mimicking other genetic skeletal dysplasias. And so MPS should be part of that differential diagnosis. The MPS 3 or Sanfilippo disorders, they might have more mild multisystemic features. The GAG accumulation in Sanfilippo is predominantly heparan sulfate, and we think that's neurotoxic. And so the MPS 3 disorders as a group, A, B, C, and D, have predominant neuronopathic effects on, which ranges from developmental delay, intellectual disability, and behavioral issues. They can be quite hyper, impulsive. And so they may not present to the ear, nose, throat doctor or the orthopedist. They will present to the pediatric neurologist, the developmental pediatrician, possibly even to psychiatry for help with ADHD. So these children might also be diagnosed with autism spectrum disorder, and so they're not going to be going through the common pathway. And it's important for my colleagues in neurology to also think MPS as part of the differential for autism spectrum, intellectual disability, and developmental delay.